Welcome to MedScroll Clinical Case Files, where we bring real-world complexity into sharp clinical focus, one long case at a time. In today's case, Miss Olivia Fletcher is a 50-year-old woman preparing for bariatric surgery in the context of severe obesity, BMI 45, and multiple comorbidities, including hypertension, sleep apnea, atrial fibrillation, and depression. Join us as we walk through her full RACP-style long case presentation, from clinical formulation to examiner discussion, model responses, and reflections on patient-centered care, symptom control, and function-focused management. Perfect for RACP, OSCES, PACES, and case-based exams. So, grab your stethoscope and join us as we begin this journey into clinical reasoning that transforms complexity into clarity.
Good morning. I would like to present the case of Ms. Olivia Fletcher, a 50-year-old European female who has been referred for assessment and optimization prior to bariatric surgery in the context of severe obesity, BMI 45, with significant associated comorbidities. Ms. Fletcher has struggled with her weight since adolescence, with major weight gain following her pregnancies. Despite multiple supervised diet and exercise programs and pharmacotherapy trials, she has been unable to sustain significant weight loss. She currently weighs 122 kilograms and is 164 centimeters tall. Her obesity is now markedly impairing her ability to carry out activities of daily living, care for her 3 young children, and maintain employment, having recently had to cease her work as a bus driver. She reports substantial distress related to weight stigma, poor self-esteem, and worsening anxiety and depression. Her comorbidities include hypertension, diagnosed at age 38, now requiring quadruple therapy with perindopril, amlodipine, moxonidine, and hydrochlorothiazide. Blood pressures remain in the borderline hypertensive range at 140 to 150 over 85 to 90 millimeters of mercury. Dyslipidaemia, currently well controlled on atorvastatin, 40 milligrams nocta, with LDL cholesterol 2.1 millimoles per liter, but persistently elevated triglycerides at 2.3 millimoles per liter. Obstructive sleep apnoea, diagnosed 5 years ago, treated with nocturnal CPAP with good adherence, although she still experiences daytime fatigue. Paroxysmal atrial fibrillation, diagnosed 2 years ago, anticoagulated with apixaban 5 milligrams twice daily, and rate controlled on bisoprolol 5 milligrams daily. She remains asymptomatic from a cardiac standpoint currently. Additional medical issues include obesity-associated knee osteoarthritis, gastroesophageal reflux disease managed with esomeprazole, and vitamin D deficiency on supplementation. She has a background of resolved iron deficiency anemia and a history of gestational diabetes, with a current HbA1c of 6.2%, indicating pre-diabetes. Psychologically, Ms. Fletcher experiences low mood, anxiety, and social isolation, for which she is managed with sertraline 100 milligrams daily and regular psychologist review. She reports significant body image distress and a sense of failure despite her best efforts at weight loss. On examination, she appears obese, but otherwise cooperative and oriented. Her blood pressure was 146 over 88 millimeters of mercury, heart rate 78 beats per minute, with an irregular rhythm consistent with atrial fibrillation, and SpO2 was 96% on room air. Cardiovascular and respiratory exams were otherwise unremarkable. Abdominal examination was benign. Musculoskeletal examination revealed right knee tenderness and reduced range of motion, contributing to an antalgic gait. Neurological examination was normal. There were no signs of fluid overload or peripheral edema. In summary, Ms. Olivia Fletcher is a 50-year-old woman with severe obesity and associated metabolic syndrome, including hypertension, dyslipidemia, OSA, and atrial fibrillation, now being assessed for bariatric surgery. Her obesity is profoundly impacting her physical, psychological, and social well-being. Severe obesity, BMI 45, with significant functional impairment, hypertension on quadruple therapy, dyslipidemia, obstructive sleep apnoea on CPAP, paroxysmal atrial fibrillation, anticoagulated, rate-controlled, anxiety and depression, obesity-related right knee osteoarthritis, gastroesophageal reflux disease, vitamin D deficiency. Severe obesity and bariatric surgery. Proceed with multidisciplinary bariatric surgery workup, including nutritional, psychological, and endocrine evaluations. Discuss risks and benefits of surgery, including expected improvements in hypertension, OSA, metabolic syndrome, and overall quality of life. Plan for nutritional supplementation and lifelong follow-up post-operatively. Post-surgical monitoring for micronutrient deficiencies, iron, B12, vitamin D, folate, calcium. Hypertension. Continue quadruple antihypertensive therapy preoperatively. Anticipate need for medication adjustment following significant weight loss. Dyslipidemia. Continue atorvastatin therapy and monitor lipid profile every 3 to 6 months. Atrial fibrillation. Maintain anticoagulation with apixaban and rate control with bisoprolol. Monitor rhythm and anticoagulation needs postoperatively. OSA. Reinforce CPAP adherence. Repeat sleep study post-weight loss to reassess severity. Mental health. Continue psychological support. Engage support networks and address self-esteem issues. Right knee osteoarthritis. Continue physiotherapy input to maintain joint function. Symptom management with paracetamol as needed, avoiding NSAIDs. GORD and vitamin D deficiency. Continue esomeprazole for reflux control. Continue vitamin D supplementation and monitor bone health.
What are the diagnostic criteria for metabolic syndrome, and how does Ms. Fletcher meet them?
The diagnostic criteria for metabolic syndrome require the presence of 3 or more of the following: elevated waist circumference, elevated triglycerides, low HDL cholesterol, elevated blood pressure, and elevated fasting glucose or prediabetes. In Ms. Fletcher's case, she meets criteria with elevated waist circumference, hypertension, dyslipidemia with high triglycerides, and impaired fasting glucose consistent with prediabetes.
How does obesity contribute to the development of hypertension, OSA, and atrial fibrillation?
Obesity contributes to hypertension via increased sympathetic nervous system activity, activation of the renin-angiotensin-aldosterone system, and physical effects like increased intravascular volume. OSA results from pharyngeal soft tissue collapse, exacerbated by central adiposity. Atrial fibrillation is promoted through left atrial dilation, increased atrial pressures, and systemic inflammation associated with obesity and sleep apnea.
What cardiovascular benefits can be expected from weight loss after bariatric surgery?
Weight loss following Bariatric surgery leads to significant improvements in cardiovascular health, including reduction in blood pressure, improvement in lipid profiles, decreased inflammatory markers, and lower incidence of atrial fibrillation recurrence. It also reduces overall cardiovascular mortality risk.
What preoperative assessments are necessary before proceeding with bariatric surgery?
The preoperative assessment for bariatric surgery includes comprehensive medical evaluation, psychological assessment, nutritional counseling, CPAP adherence, evaluation for OSA, and endocrinological review for glycemic and lipid control. Fitness for anesthesia and surgery, as well as commitment to postoperative lifestyle changes, must be confirmed.
How do Roux-en-Y gastric bypass and sleeve gastrectomy compare in terms of mechanism and outcomes?
Roux-en-Y gastric bypass combines restrictive and malabsorptive mechanisms and induces hormonal changes such as increased GLP-1 secretion, leading to greater weight loss and metabolic improvements. Sleeve gastrectomy is primarily restrictive but also has hormonal effects. Both lead to significant weight loss, but bypass typically results in slightly higher rates of diabetes and hypertension remission, though it carries higher nutritional deficiency risks.
What are the common nutritional deficiencies following bariatric surgery and how are they managed?
The most common nutritional deficiencies post-bariatric surgery include iron, vitamin B12, folate, calcium, vitamin D, and occasionally thiamine, lifelong multivitamin supplementation, regular biochemical monitoring, and early intervention if deficiencies are detected are critical to preventing long-term complications.
How would you manage atrial fibrillation in the perioperative and postoperative periods of bariatric surgery?
In managing AF around the time of bariatric surgery, anticoagulation needs careful consideration to balance thrombotic and bleeding risks. We would coordinate with the anesthetic and surgical team regarding perioperative anticoagulation bridging strategies. Postoperatively, weight loss may reduce AF burden, but rhythm monitoring should continue and anticoagulation reviewed depending on CHA2DS2VAS, C-score, and AF burden.
How should antihypertensive therapy be adjusted following significant weight loss?
After substantial weight loss, antihypertensive requirements often decline. I would monitor blood pressure closely postoperatively and anticipate the need to de-escalate antihypertensive therapy to prevent hypotension, particularly diuretics and vasodilators first, while continuing to monitor renal function and electrolytes.
How would you sensitively discuss weight and bariatric surgery with a patient who has experienced stigma?
When discussing weight with Ms. Fletcher, I would adopt a non-judgmental, empathetic approach. I would acknowledge the challenges of weight loss and avoid attributing blame. I would focus the conversation on health benefits rather than appearance, using motivational interviewing techniques to explore her goals and readiness for change.
What psychosocial factors would you consider in assessing suitability for bariatric surgery?
I would consider factors such as her mental health stability, coping mechanisms, social support, history of disordered eating, and ability to engage with post-operative follow-up. Given her anxiety and depression, collaboration with her psychologist would be essential to ensure readiness for surgery and post-operative challenges.
How would you coordinate multidisciplinary care in a patient undergoing bariatric surgery?
Multidisciplinary coordination involves bariatric surgeons, dietitians, endocrinologists, psychologists, anaesthetists, and her GP. Regular case conferences, shared documentation, and clear communication pathways would be essential to ensure seamless care and address any emerging issues early.
What support would you arrange for a sole carer of young children undergoing bariatric surgery?
Recognizing her responsibilities as a sole carer for 3 young children, early discharge planning would involve social work input, arranging home support services if needed, and ensuring community nursing follow-up. Preoperative planning should explore potential child care arrangements during her recovery period.
What are the mental health risks following bariatric surgery, and how would you address them?
Patients undergoing bariatric surgery are at increased risk of depression, anxiety, eating disorders, and even suicidality post-operatively. Close monitoring, continuation of psychological therapy, proactive mental health screening, and early intervention would be critical to mitigate these risks.
How would you address a patient's sense of failure despite previous lifestyle efforts to lose weight?
I would validate her efforts and explain that in severe obesity, biological factors, including hormonal adaptations and metabolic set points, often prevent sustained weight loss through lifestyle measures alone. I would reinforce that bariatric surgery is a medical tool, not a failure of willpower.
How would you counsel a patient about the long-term lifestyle changes required after bariatric surgery?
I would explain that bariatric surgery requires lifelong commitment to healthy eating, portion control, regular exercise, nutritional supplementation, and attendance at follow-up appointments. Emphasizing education and setting realistic expectations are crucial for long-term success.
How would you support this patient's mental health as part of the overall care plan?
I would ensure her ongoing access to psychological support, monitor for exacerbations of anxiety or depression, and encourage participation in peer support groups. A holistic approach addressing both physical and mental health would be key to her successful recovery and adaptation.
Ms. Fletcher's case reminds us that obesity is not simply about weight, but a multi-dimensional health challenge that deserves empathy, strategy, and science. Thanks for watching MedScroll Clinical Case Files, where medicine gets personal. Don't forget to like, comment your thoughts, and subscribe for more real-world clinical deep dives. See you in the next case.